morning, good afternoon, and good evening to all the speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to the ACNS webinar. The speaker for the first session today is our honorable guest from Japan, Professor Takahiro Ota. Professor Ota is the director of the Department of Neurosurgery, Tokyo Metropolitan Tama Medical Center, Tokyo. He's a stroke specialist certified by the Japanese Stroke Society. His clinical interests are focused upon surgical and endovascular management of cerebrovascular diseases such as aneurysm, infarction, carotid artery stenosis, and AVM. We are extremely honored to have him today at our webinar, and today he'll be talking about clinical relevance of persistent carotid basilar anastomosis. The speaker for second session today is our honored guest from China, Professor Zhang Qiang. Professor Zhang is the consultant neurosurgeon at the Neurosurgical Department of Beijing Tiantan Hospital, Capital Medical University. He's also the Vice Director of the Second Ward of Vascular Diseases of Beijing Tiantan Hospital. He went to Belgium to study minimally invasive neurosurgery at the Erasmus Hospital. In 2018, he focused on basic research and also surgical treatment of Moyamoya disease in the Neurosurgical Department of Stanford University. He specialized in surgical treatment of cerebrovascular diseases such as Moyamoya disease, carotid artery stenosis, intracranial aneurysm, and cerebrovascular malformation. We are extremely honored to have him at our webinar today, and he will be talking about importance of periventricular anastomosis. The chair for the first session today is our honored guest from United States of America, Professor Muhammad Aziz Sultan. Professor Sultan is the Chief of Division of Vascular and Endovascular Neurosurgery in the Department of Neurosurgery and also a core director of the Comprehensive Stroke Center and Associate Professor of Neurosurgery at Harvard Medical School. He was awarded the Distinguished Clinician Award in 2021 by the Brigham Health. He's also the lead researcher engaged in various trials on cerebrovascular neurosurgery. He's working on novel projects, including application of biomarker and stem cell in the diagnosis and the treatment of stroke. He has also collaborated with Brigham's and Women Neuro-Oncology Group to utilize cerebrovascular imaging, assess, and drug delivery for brain tumor. He's being a mentor to many neurosurgical resident and active proponent of global neurosurgery. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session today of our webinar is our honorable guest from China, Professor Zhu Bin. Professor Zhu Bin is a consultant neurosurgeon at the Huashan Hospital, Fudan University, China. He's also the vice president of the ACNS. His clinical interests are focusing on management of cerebrovascular diseases, especially Moyamoya disease. He has the world's largest series of operated cases of bypass for Moyamoya disease. He's also an icon on online education who supported the ACNS webinar from time its inception. He's also run the China Grand Rounds with the excellent online platform for young neurosurgeons. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and chairs and the wonderful audiences on this online platform of ACNS webinar. A warm welcome to our colleague in China, and again, we are extremely thankful to Professor Zhu Bin for broadcasting this webinar on WeChat channel. Professor Raja will be co-hosting with me today. And with that introduction, I would like to hand over this online podium to our first chair, Professor Muhammad Ali Sultan. Professor, please.
Thank you so much for the kind introduction. First of all, let me congratulate you on a beautiful forum of getting people. You have the leaders from China, from Japan, India. It's such a beautiful forum. Despite the titles and introduction, I'm a young boy from Afghanistan, and there are people like this in the audience that now have access because of what you're doing to the brightest and best minds in the world. So thank you so much for putting this together. Thank you for Professor Kato and Professor Bin for their hard work. I am so excited to hear Professor Ota regarding what I think the first thing that surgeons should be is great anatomists, to understand the anatomy, to understand the vasculature, and not be technicians first and foremost. And so I'm very, very excited to hear this lecture. we run into these anastomoses and sort of think about, oh, maybe this led to an aneurysm, but to really understand the clinical relevance and diagnose and potentially think about treatment from an embryological standpoint. So I'm very excited to hear, Professor from Japan. I'm so glad to collaborate with Japanese and help train and learn from them. Please, very excited to hear from you.
Thank you, Professor Sultan, for introducing me. And a few comments at the beginning from me. Embryology and functional neuroanatomy may not be familiar to many neurosurgeons. I used to be the same, but to the knowledge of embryology and functional neuroanatomy enable us to understanding the anatomical variants or pathophysiology of the arterial anatomy, especially the today topic of carotid basilar anastomosis. This carotid basilar anastomosis is very interesting and very stimulating to me. So I do hope you enjoy my lecture. Good evening, everyone. I'm Takahiro Ota from Japan. I'm glad to have a chance to tell you about clinical relevance of persistent carotid basilar anastomosis. The persistent carotid basilar anastomosis are anatomical arterial communications between the anterior and posterior circulations due to abnormal embryological development of the vertebro-basilar system. These carotid basilar anastomosis usually disappear during embryogenesis. Primitive carotid basilar anastomosis includes 4 types: primitive trigeminal artery, PTA, primitive aortic artery, primitive hypoglossal artery, PHA, and primitive parietal artery. Their names, with the exception of the parietal artery, using the cranial nerves which they run. Among these, the primitive aortic artery has been questioned and will not be covered in this today's lecture. This is an outline of my presentation today. I will first give a little background on the embryology and primitive lateral basilar vertebral anastomosis, which is called PLBA. PLBA is one of the key words in today's presentation. Then I will explain the primitive trigeminal artery and PTA variants. Finally, I will show you some case reports and discuss about PHA and PPA and their variants. Let's start with the first topic, embryology and PLBA. In the early embryological period, the hindbrain is supplied by the carotid basilar anastomosis, which are arranged from rostral to caudal hindbrain as follows: trigeminal, hypoglossal, and proatlantal arteries. To add explanation, the hindbrain later develops the pons, the medulla, and the cerebellum. These transient anastomosis rapidly regress in about a week, and the posterior communicating artery, PCOM, develops, and basilar arteries supplied from the vertebral arteries finally. The basic direction of arterial blood flow to the hindbrain is from the internal carotid artery, ICA, to the basilar artery. And proximal basilar artery and vertebral arteries are hypoplastic or aplastic in the case with a less demand of blood supply from the vertebral artery. This is a diagram of the brainstem vasculature. As you can see, the left figure shows the basic pattern of angular architecture of the brainstem. We have longitudinal anastomosis at midline and lateral. Basilar artery is formed by fusion of 2 longitudinal neural arteries, LNA. We can explain cervical, spinal, and brainstem vasculature by the longitudinal and axial arteries. PTA is here. I'd like you to focus on this green line. PLBA. I will discuss PLBA next. During development, two longitudinal anastomosis or channels can be seen on the hindbrain. This is LNA and this is PLBA. In 1948, Paget described this anastomosis as PLBA. PLBA is a temporally longitudinal anastomotic channel. And what is the role of PLBA? The PLBA is a prominent vascular network from the 5th week to the 7th week of human hindbrain development. There are many transverse channels between LNA and PLBA. Some of these later constitute of the proximal segment of the cerebellar arteries. You can see that the PLBA is not one artery. It is an arterial network. During the development, PLBA showed various patterns as a result of the fusion and regression. Left figure shows the embryo at the stage of crown rump length CRL 5 to 7 mm. PLBA is supplied by the posterior branch of the proattental artery. This and cranially by the lateral branches of LNA and particularly PTA. Right figure at the stage of CRA 16 to 18 mm, the ICA and PICA do not have branches to the cerebellum. Note that the SCA develops and is the only artery supplying the cerebellar rudiment. Here, the ICA only has a choroidal branch, and the main trunk of the PICA is not formed and exists as a vascular network on the lateral side of the medulla. At this time, ICA and PICA do not have branches to the cerebellum. SCA develop first, and ICA and PICA develop later. The important thing is that the PLBA contributes to forming the proximal segment of these cerebellar arteries. The transverse artery from the longitudinal channel LNA and PLBA is enlarged to meet the demands of the cerebellum and brainstem. In an embryo of CRA 40 mm, the circle width is fully recognizable. Besides the SCA, the ICA and PICA have become more prominent in the vascular plexus that still covers the caudal hindbrain. Okay. The second topic is primitive trigeminal artery, PTA. Persistent primitive trigeminal artery, persistent PTA, is the most common persistent primitive carotid basilar anastomosis. I'm sure you have been seeing the case with PTA several times, and its angiographic prevalence has ranged from 0.5 to 0.7%. PTA originates from ICA C45 and merges basilar artery between SCA and ICA. In the right schema, longitudinal artery are LNA and PLDA, and axial arteries are SCA, ICA, PICA, paramedian artery, and circumferential artery. Red line indicates the primitive trigeminal artery, which connect ICA and basilar artery. As many of you already know, this is Salaz's classification. PTA has two types, medial and lateral. Medial type enters the posterior fossa from a foramen in the dorsum sellae. On the other hand, lateral type enters Meckel's cave, causes posteriorly, bends sharply medially, and connects to the basilar artery as shown here. This figure tells us 5 types of PTA classified by the dominance of PCA. Bilateral PCA, one-side PCA. But in the lower 3 types are PTA directly connects to the cerebral arteries, that are so-called PTA cerebral artery variants. I will discuss PTA variants later. Now I will show you some case reports and discuss about PTA and cerebrovascular diseases. First, PTA and aneurysm. The PTA itself is a potential site of aneurysm formation. The aneurysms occur in 14 to 32% of PTAs. So the discussion is here is the aneurysm formation due to dysplasia or hemodynamic stress. The PTA aneurysm may be located on A. At the bifurcation of the cavernous IC segment and the PTA. B. The PTA trunk itself. C. At the junction with the basilar artery. This is our case. C has a right ICA large aneurysm. And this is 3D rotation angiography. And this shows you can see the PTA originate from the neck of the aneurysm, and PTA directly connect to the SCA. So this is this aneurysm is ICA and PTA variant aneurysm. We treated this case with pipeline, and 6 months later, the aneurysm has gone and PTSD variant is preserved. Second, PT and hospital AVM. You can see the hospital AVM and the PT is large, and the main feeder of the nidus is right PCA. In this paper, the authors reviewed 13 reports. Most of presentations were hemorrhagic stroke. In a small subset, there are trigeminal neuralgia in some cases. And the authors discussed the associations of AVM and PTA were incidental in almost all cases. AVMs were located ipsilateral to the PTA. So here is a question. Persistence of PTA and AVM development are related. The author discussed they are incidental. Third, this is a post-traumatic trigeminal cavernous fistula. The patient has a prior traffic accident and presented with swelling in the right eye, pulsation, lag ophthalmos, etc. You can see the PTA and the cavernous fistula. And they treated onyx embolization. They initially misdiagnosed this case as a CCF, but left VA injection showed early filling of cavernous sinus, and Olcott maneuver revealed a PTA connection. Fourth, PTA and ischemic stroke may be most likely to be encountered in clinical practice. In the case of anterior circulation thrombus, the PTA can lead to migration of the thrombus to the basilar artery, possibly causing a posterior circulation stroke. In basilar hyperplasia, about 40% of PTA, mechanical thrombectomy must be performed via the PTA in the posterior circulation strokes. Thrombosis of PTA itself remains a rare phenomenon. Several transient episodes compatible with vertebral basilar insufficiency, example vertigo. We consider that as signs of PTA-related stroke. we may have a chance to treat large vessel occlusion in the patients with PTA. In this case, a diffusion with image showed the right hemisphere infarction, and you can see the IC and M1 occlusion, also basilar occlusion. This MC and basilar occlusion, and mechanical thrombectomy for basilar occlusion was performed through PTA. Because the patient has bilateral V hypoplastic and PT was patent. Another case, IC occlusion with PTA. This case shows the left hemisphere in stroke and the left IC occlusion. And this white arrow head shows PTA and white arrow shows ICA. So intracranial part of the IC and MCL was not shown. They discuss prior MRI if any prior MRI was useful, and they required to prevent the ENT to put the posterior circulation through PTA. They selected combined technique, and the result was TG3. Puncture to recanalization was 21 minutes. This is a final angio, and the complete recanalization of the ICA. So if ICA and basilar arterial occlusion coexist, we should consider the existence of the carotid basilar anastomosis. There are some cases in which PTA compresses the cranial nerves. This is a case with trigeminal neuralgia caused by a PTA variant. This is the intraoperative view and the figure. This is a trigeminal nerve, and the PTA variant compresses the trigeminal nerve. Developmentally and anatomically, the PTA could involve the cranial nerve 3, 4, 5, and 6 in its course through the cavernous sinus and the preponte system. You can understand well. I will show you another case. This case also has a PTSC variant, and it compressed the trigeminal artery. PTA ran across Meckel's cave and compressed the cisternal segment of the nerve cautery. The incidence of PTA among patients with trigeminal nerve was 2.2%, which is much higher than that found in the general population. PTA also compresses the oculomotor nerve and abducens nerve. I think it's important to remember that this is a possibility. Face syndrome, which is the most common neurocutaneous vascular disorder, comprises a spectrum of anomalies including posterior fossa malformation, hemangioma, arterial anomalies, cardiac defects, eye anomalies. Patients with face syndrome display a wide variety of arterial anomalies that can be categorized as dysplastic, narrowed, or aberrant cause or origin, or as persistent embryonic vessels. PTA occurs more frequently among children with face syndrome, 12 to 60%, than in general populations, 0.1 to 0.2%. To summarize these case reports, we can find the PTA with aneurysm, AVM, cerebral infarction, trigeminal neuralgia, face syndrome, etc. Next, I will discuss about PTA variants. These are embryologically very interesting. I will show you some cases with PTA variants. Left figure shows PTA, the circumferential branch variant. There is No direct interaction with the basilar artery. Middle, this is our case, a PTA-ICA variant. A PTA directly connects to the ICA. And blue shows the 3D rotational angiography of ICA. Red shows the basilar artery 3D rotational angiography. Right figure shows the PTA-PICA variants in the literature. Did you experience the PTA variants like this? Let's discuss about PTA variant from the embryological point of view. Left figure, Houghton explained by an incomplete fusion of RNA. This longitudinal artery is RNA, and this is PTA, the PTA SC variant, PTA ICA variant. But this is unlikely. In 2017, Greg describes that PTA variant results from the partial persistence of the PLBA. This is PLBA, this is PLBA, this is PLBA. Greg's explanation is more reasonable. There are three reasons. PTA establishes anastomosis with PLBA before joining RNA. PLBA is located laterally than RNA. SCA-ICA, PICA were recruited secondarily and formed from the transverse network PLBA. So the point here is partial persistence of PLBA. As we discussed here, several interpretations of PTA variants are possible. This is schema, and the red line shows PTA. And this is PTA paramedian or PTA circumferential variants. These are result of incomplete fusion of the RNAs. This is RNA. Then the PTA cerebral artery, PTA-SCA, PTA-ICA, PTA-PICA variants are results from the persistence of part of the PLBA. And these variants occur when the transverse connection PTA to RNA is absent. Depending on the site of incomplete fusion and remnant anastomosis, this may result in various patterns of PTA variants. Let's see this rare case. Right view injection, epi view, and lateral view. You can see middle meningeal artery MMA originate directly from the basilar artery. Next case. In this case, ophthalmic artery originate directly from the basilar artery. So, how can you explain these rare cases? Analysis of the longitudinal axial blood supply of the brainstem helps to understand the pattern of PTA variants as discussed earlier. PTA exclusively supplying a part of the cerebellum was reported. We call it as a trigeminal cerebellar variant. This purple line. This is the trigeminal artery and this is cerebellar artery. These variants can be explained by the trigeminal artery being incorporated with other embryonic arteries such as the primitive staphyloid artery, this green line, or orbital artery. The MMA arising from the basilar artery can be understood embryologically as a trigeminal artery taking over the territory of the intracranial branch of the stapedial artery. So this variant could be called a trigeminal stapedial variant. The ophthalmic artery from basilar artery is explained by the embryonic connections among trigeminal artery, stapedial artery, and orbital artery. Could be regarded as trigeminostapedophthalmic variant. But these variants are off the subject of today's discussion. Back to the story. Next, I'd like to address primitive hypoglossal artery. Primitive hypoglossal artery is the second most common persistent carotid basilar anastomosis, and its incidence ranging from 0.027 to 0.29%. The PHA arises as a branch of the IC and transverses the hypoglossal canal to join the lower portion of the basilar artery. The ipsilateral V and PCOM are often aplastic or hypoplastic. Remnant of the PHA in adults is considered to be the hypoglossal branch of the ascending pharyngeal artery. So this hypothesis can explain the PHA originating from the ECA. Most of primitive hypoglossal arteries are incidentally found, but less than 10 cases with bilateral primitive hypoglossal artery have been reported, shown in this case. Bilateral VAs were hypoplastic and bilateral primitive arteries passed through the hypoglossal canal. PHA were found more common in female left side, associated with several cerebrovascular diseases. In the ischemic strokes, PHA affects both anterior and posterior circulations. Especially, the majority of the cases with PHA and ischemic strokes attributes to the atherosclerotic artery to embolization from the ICA through PHA. A basilar artery fenestration is due to the failure of fusion of RNAs and is associated with vertebral-basilar junction aneurysms. You can see the left ICAZ show that this is PHA and this is aneurysm. And you can see the aneurysm by basilar artery fenestration. The fragility of the vascular wall and or hemodynamic stress due to the presence of a PHA are reportedly related to aneurysm formation. About 30% were located at the PHA basilar junction, 50% in the posterior circulation. So it's important to recognize that PHA is a major vessel in the posterior circulation. In this case, you can see the cervical ICA severe stenosis. And the patient had the transient episode of left lower extremity numbness and weakness, MRI revealed right watershed infarction and severe ICA stenosis. We can see the retrograde filling from the vertebral junction to the distal cervical ICA through the PHA. This is PHA, and this is muscle branch. So PHA is a major vessel in the posterior circulation when the VA or basilarity are hypoplastic or aplastic, or stenosis or occlusion. Little attention is required during carotid artery stenting in the case with PHA. This is ICA, this is stenosis and PHA, and double distal filter. You can see this was placed on both distal ICA and primitive hypoglossal artery, respectively. In performing carotid artery stenting for cervical ICA stenosis with PHA, it is considered important to select appropriate embolic protection for each case. This is our case, ICA symptomatic stenosis, and we navigated double filter protection, this here and here. Then we put two wall stent, and this is the last figure. This is a case with IC stenosis and ipsilateral PHA, presenting as a multi-territorial, right frontal and cerebral. Multi-territorial embolic infarction. Usually we consider cardiac embolism as a cause of multilobular infarction, but I'd like to stress that it's necessary to recognize persistent carotid basilar anastomosis could be one of the causes of simultaneous acute infarctions in both anterior and posterior vascular territory. Right case, the main feeder of event was posterior cerebral artery, but this is a large primitive hypoglossal artery, so they approach the nida through the PHA. As the PTA in basilar artery hyperplasia, intervention must be performed via the PHA in the posterior circulation large vessel occlusion or AVMs. I will show you an extremely rare PHA case known as the PHA variant. This hypoplastic PHA directly ends in the pica without an interposed segment of the basilar artery via the hypoglossal canal, which arises from the extracranial segment of the ICA or the ECA. On the other hand, to my knowledge, the PHA-CA and the PHA-ICA variants have not been reported so far. The embryonic hypoglossal arteries are composed of three parts as shown in the figure. Red line is the hypoglossal artery proper. Big yellow line. This is the portions of the PLBA. Green line. This is the transverse anastomotic channels connecting PLBA and longitudinal artery. The PHA-PICA variant results from the persistence of the first red part and second yellow part, and evolution or failure of development of the third part green of the PHA. Last topic of this lecture is the primitive proatlantal artery, PPA. In the early embryogenesis, proatlantal artery supplies the caudal part of the longitudinal neural artery and PLBA, as shown in the figure. PPA has two types. The type 1 PPA arising from the posterior aspects of the ICA and courses between C1 arch and occiput for its first vertebral space before entering the foramen magnum. Type 2, right figure, it originates from the proximal ECA, travels between the C1 and C2 intervertebral space to join the vertebral artery. This is another figure. This is type 1 proatlantal artery, and this is type 2 proatlantal artery. Angiographically, the PPA is often confused with the primitive hypoglossal artery. PHA enters the skull via the hypoglossal canal. PPA passes through the foramen magnum. PPA type 1 passes through the foramen magnum. Type 1 and type 2 PPA may be regarded as persistence of the C1 and C2 segmental artery respectively. You can see bilateral PPA and absence of both VAs by aortography. I'd like to stress that the persistence of carotid basilar anastomosis are related to preservation of blood flow to the posterior fossa compromised by hypoplastic or non-existent basilar arteries. In this case, bilateral VAs were hypoplastic, and PPA is the sole artery supplying the posterior circulation. Within the setting of PPA, the presence of additional vascular abnormalities has been reported as frequently as 59% of cases, including multiple reports of aneurysm. The PPA was the sole artery supplying the posterior circulation. That means PPA was the sole artery as a route to posterior circulation. So they embolized the aneurysm through the PPA. This case, basilar artery occlusion and persistent primitive pro-alternate artery. So, how can we access to the basilar artery? Of course, through the PPA. They used slumber technique. The result was TK3. So I'd like to stress again that prompt recognition and identification of persistent carotid basilar anastomosis is paramount to plan mechanical thrombectomy. Finally, let's discuss rare cases. So, this case, cerebellar infections, and white arrowhead shows any persistent primitive artery, because this is IC and this is upper part of the basilar artery. And DSA also show the primitive artery connect between IC and basilar artery. But this persistent primitive artery passes through the jugular foramen. This really shows that primitive persistent primitive artery runs through the jugular artery. This artery is not primitive hypoglossal artery nor primitive pro-antral artery. So the name of this primitive artery is not elucidated. Another rare case. This is a persistent carotid basilar anastomosis with the name transcribal artery. Because hypoglossal canal is here and this transcribal canal is not the same with the hypoglossal canal, rather medial. So this anomalous vessel they call transcribal artery. I'm sure there are still unknown carotid basilar anastomosis, but its embryological origin is not elucidated. I'm looking forward to other case reports. This is the conclusion slide. In the early embryological period, the hindbrain is supplied by the carotid vertebral basilar anastomosis. Partial persistence of the PLBA explains the formation of commonly observed carotid basilar anastomosis variations such as PT variant and PHA variant. Prompt recognition and identification of persistent carotid basilar anastomosis is paramount to plan neurointervention, especially in mechanical thrombectomy. Thank you for your attention. And this is the last slide. The FAN conference, Functional Anatomy and Neuroangiology Conference 2023, will be held on July 1st. The conference is open to everyone who are interested in functional neuroanatomy and neuroangiology for interventional neuroradiology. We are looking forward to your participation. Thank you for your attention again.
Thank you so much. That was a Wonderful talk, going into the embryology and the formation. Some things I learned, never knew that the anastomosis, the metameningeal can come from the basilar. I think you described its relevance in aneurysms, possibly in AVMs, stroke, and compressive syndromes. I have just two questions. One, in terms of aneurysm, let's say you find persistent trigeminal and so forth. Do you continue, if the patient doesn't have aneurysm, do you continue to monitor these patients? Because in some cases it's 30%. And do you follow them? And how long do you do that if you do follow them?
I think you do not need follow them. If you find an aneurysm in the patient with PTA, then you have to follow the patient.
Thank you. Any of the other professors do anything different? Or if there's no aneurysm, you stop following?
Yeah, that's right.
Right. Okay. The second question is a technical question. And when first stent retrievers came, I used to, when I was younger, go through PCOM and into the MCA when the ICA was completely occluded and so forth. And I thought that was a cool, roundabout way of getting there. So now, if you have a posterior circulation occlusion, but you have a vertebral system in place, my fear is that you're dragging clot from the anterior circulation, from the posterior circulation into the anterior circulation, and causing two territories. So if you still have the vertebral system, do you still prefer to go to the persistent, or?
It depends on the cases, So if the carotid vaginal anastomosis persists, the antegrade flow from the IC anterior circulation to posterior circulation. So it's important thing. So we have to decide. Probably I chose the strategy with the two guiding catheter, or one guiding catheter and one diagnostic catheter in the anterior circulation and posterior circulation. It depends on the cases.
Sure. Thank you. Thank you. Excellent lecture.
There's a question. Ben, you want to ask a question?
Okay.
Yes. Hello, Professor Otta. I'm
Yes.
Dr. Ben from Hong Kong, work with young neurosurgeon specialist, mainly in skull-based and also vascular surgery in Hong Kong. So thank you for your lecture. I really enjoy listening to your lecture. Very knowledgeable and detailed explanation concerning those primitive vessels. So my question is that in your lecture, you're mainly talking about the relationship of this vessel with aneurysm and AVM. But I do encounter rare cases that these vessels are associated with some skull-based tumor. For example, petrocalcium meningioma encasing on the persistent trigeminal artery. Although it's rare, but it is occasionally happen. So my question is that in your literature review, any special mentioning about this, how to deal with these vessels during your review? If we encounter this vessel, how should we deal with them? And my second question is also about this primitive vessel associated with the skull-based tumor. So how can we assess whether this vessel can be sacrificed or not? So, for example, if the tumor if the tumor encased the persistent trigeminal artery. So is there a preoperative angiographic study like balloon occlusion test that we need to perform to see whether this vessel can be sacrificed? How should we assess the perfusion when we encounter this kind of vessels? Thank you so much.
Thank you for a question. That is a nice question. And whether we can sacrifice the primitive artery or not, in most cases, we cannot sacrifice them. And as you already said, balloon test occlusion or balloon occlusion test is useful if we need it to assess the necessity of sacrificing them. But the persistent primitive artery exist because they are they supply the posterior circulation. So if when primitive artery is should be preserved in any case, I think.
Yes, may I ask if you consider perform a balloon occlusion test in a patient with these primitive vessels? So what is your sequence of injection, or with any precaution during the study that you need to consider when you perform balloon occlusion in this kind of patient?
Unfortunately, I do not have a case with the skull-base meningioma or skull-base tumor with primitive arteries, and I do not have experience with PTA in such cases. But I don't like to the balloon test occlusion in the posterior circulation. So if possible, you can skip. You have to skip the balloon test occlusion. But in my literature review, not a few cases were about the skull-base meningioma or skull-base tumors. So probably they are not found in the skull-base tumors. But one thing I should comment is that we had to assess the angiography or CT angiography or MRI angiography before skull-base tumors, as tumor operations. Thank you.
Yes, wonderful. Thank you so much, Professor. I totally agree that these vessels are very important to handle.
Yes.
Thank you so much.
Any other questions from the audience?
Yeah. May I ask one question, Professor?
Yes.
Yeah, I just wonder, since we're talking about embryology and diseases in vascular disease, cerebral vascular diseases, and when we encounter cases, for example, cerebral aneurysm with some primitive vascular supply, how do we put that? Because in the insurance forms that we ask whether this is part of the congenital disease or not. So, and again, we have a lot of a debate regarding AVM, whether they are congenital or non-congenital. There are cases that AVM forms later, at a later stage in human. How about those aneurysms with the primitive circulation? How do we classify them, whether it's congenital or non-congenital diseases? Thank you, Professor.
That is a nice question, and AVM is considered to be not congenital in recent years, I think, and aneurysm formation is due to hemodynamic stress because of the existence of primitive arteries, I think. So the cerebral aneurysm and arteriovenous malformation are not should be separated, considered.
One more additional question, Professor. You show a case that with the bilateral vertebral artery hypoplasia, and there is a primitive flow from a proatlas. in those, if the patient is symptomatic, what is your recommendation? Symptomatic of ischemia, for example, what is your recommendation of the treatment of choice in those patients? Thank you.
If the patient had a stenosis in the primitive arteries, so we have to consider the stenting or PTA, I think.
Any role of bypasses surgery for those cases beside that?
Yeah, that hard to answer. But bypass surgery is probably not indicated in the case with primitive arteries, I think.
Thank you, Professor.
Thank you.
I don't see Professor Zubin. Do you have any question from you, Professor?
No, no question. Thank you, Professor Ota, for your very informative presentation, and I also learned a lot. Thank you.
You're welcome. Thank you very much.
There are also another question in the chat box, so we hand over back to Professor Ali for his concluding remark before we move on to the second lecture, Professor.
Yes, again, I think reiterating for neurosurgeons, for interventionalists, the importance of understanding anatomy, of understanding embryology. It's a map of not only how to proceed technically with the procedure, but also to figure out what is associated, what can be managed. So it's a very, very, very important concept. Originally, a number of the French and these neuroangiographies were exquisite anatomists before they were anything else. So I think this lecture really, really points out to the importance of this science. Thank you. Wonderful lecture.
Thank you very much to Professor Ota for a very fascinating lecture for all of us, and also Professor Ansotan for chairing this session. So now it's time for us to move on to the second lecture. I would like to call upon Professor Zubin to introduce our second speaker, Professor.
Yeah, thank you, Dr. Liu. And Zhang Chen, Professor Zhang Chen is from Beijing Tiantang Hospital, the biggest neurosurgical department in China. And he is a very talented young neurosurgeon, and he is already chief physician. And now, Professor Zhang Chen, the time is yours.
Thank you, Professor Xu. Dear Professor Xu, Professor Bonsan Liu, and Ali Sultan, Professor Ota, and Raja, and dear colleagues online, it's my honor to be here to attend the ACNS program. I'm Chen Zhang from Beijing Tiantang Hospital. Today, my topic is Moyamoya disease. I'll talk something about the periventricular anastomosis. This is my outline. First, I'll talk something about the concept of Moyamoya disease. Second, we'll introduction the periventricular anastomosis. Third, we'll to tell something the evaluation method and the clinical significance of PA in Moyamoya disease patients. Last, I'll talk something about the research progression of periventricular anastomosis. Moyamoya disease is a chronic cerebrovascular disease characterized by progressive narrowing of the distal internal carotid artery and their proximal branches with abnormal collateral vessels. From the human's neurosurgical surgery and the article published by Hawking, we can see the typical angiography manifestation is Moyamoya vessel. The spatial distribution of Moyamoya vessel can be classified as ethmoidal Moyamoya vessel, the Moyamoya vessel in basal ganglion and the thalamus, and also the wild Moyamoya. This is the picture from the intraoperative, and this is the histological features of MMD patients' endothelial cell. For epidemiological features, MMD was more common in East Asia countries such as Japan, Korea, and China. The incidence of Moyamoya disease has been increased during past decades. In 1992, we can see there are nearly 5,000 cases reported all over the world. Now it was reported nearly in every country. The highest is still in East Asia. This data was from China. In China, this disease was more common in Jiangxi province and Henan province and Anhui provinces. The annual incidence of Moyamoya disease in China was about 1.14 per 100,000 inhabitants. The age at onset characterized as a bimodal pattern, the age peak and the adult peak. For clinical manifestation, some patients presented with asymptomatic or mild symptomatic, just maybe a headache. Most common in manifestation is ischemic manifestation, including transient ischemic attack, infection. About 20% of adult patients presented with hemorrhage. For radiological diagnosis, the DSA is the golden standard. We can see the narrow or occluding of MCA, ACA, or PCA, and the collateral from external carotid artery or the base of the skull. We can observe these collaterals. For MR imaging, we can see infection, and at the base system, we can see Moyamoya vessels. For the perfusion evaluation, we can use CT perfusion, MR perfusion, and MR ASL imaging. Also, we can use SPECT or PET examination to evaluate the hemodynamic state for patients. This is the pathology of Moyamoya disease. This is from the picture of autopsy. We can see thickening in intima and thin medial stenosis artery. The typical manifestation is Moyamoya vessel. So the pathogenesis of Moyamoya disease is still poorly understood. Usually we accept the double hit hypothesis. Maybe some patients has gene mutation, some environment factor or immunological factor or hemodynamic factor will trigger the disease. These some genes involved in Moyamoya disease and causing Moyamoya disease. From OMIM, there were 4 genes identified. In 2010, the RF213 was identified in East Asia MMD patients and Caucasian MMD patients. BRCC3, ACT2, and the GUCY1A3 was identified in some family cases in Caucasian patients. 2 years ago, a DIA-PH1 was identified in Caucasian MMD patients. Usually, these patients will have a the decreased number of platelets. However, the exact mechanism of this gene or the environment factor to lead the Moyamoya disease is still unclear. In East Asia, RF213 is the major susceptibility gene for MMD. In Japan and in Korea, there were about 17 to 80% of patients carried the variant of RF213. In China, it was lower. It's about 20 to 30% of patients carried this variant. Early onset and a high cumulative risk of stroke in patients with RF213 4810 variant was observed. However, in animal model, in the transgenic zebrafish or knock-in, knockout mouse, we cannot observe the typical Moyamoya vessel. So the role of RF213 in MMD remains unclear. Next, I will talk something about the periventricular anastomosis. It's a kind of pathological anastomosis between perforating arteries and the medullary arteries in the periventricular region. Professor from Japan, Takahashi, first described the angiographic features of anastomosis between perforating arteries and the medullary arteries in 1980s. Usually, the PA can be classified into three groups. The first group is lenticulostriate artery. The second group is thalamic artery. The third group is choroidal artery. From the embryological perspective, for normal human being, centripetal and centrifugal models of the white matter blood system was formed. We can see for the deep white matter, usually the M4 and the artery from ACA will supply the white matter from outside to inside. At the same time, there was some artery, for example, the LSA or thalamic artery or choroidal artery will from inside to outside to supply this deep white matter. So for Modi's report, there were 6 kind of blood supply for white matter. So for type 1, it is a kind of cortex depends on short arterioles originating from the same higher vessels. For type 2, is the corpus callosum is supplied by short arteriole from the higher network. Usually is from single sources. Type 3, we can see the short U-shaped fibers are supplied by subcortical arteries and the earliest branches of medullary arteries. For type 4, the external capsule or extreme capsule take up subcortical arteries, the earliest branches of medullary artery and the terminal of perforating artery of the base of the brain. Sometimes is triple sources blood supply. Type 5, the central semiwall is supplied here and by terminal of deep white matter arteries. Type 6, usually the basal ganglia and the thalamus are long perforating arteries from the base of the brain. So an important article published last year is the single cell RNA sequencing results from Science. It reviewed the for human beings the distribution of cerebral vascular cells, including endothelial cell, smooth muscle cell, some fibrous cells, and immune cells. So for green matter, increased cell density was observed. For white matter, decreased cell density for vessel was observed. So, however, for MMD patients in white matter, medullary artery was dilated, so it was different from the normal human being. So let's see the periventricular anastomosis in MMD and a normal human being. So we nearly cannot see LSA or choroidal artery. However, in MMD patients, this artery was dilated obviously. So another question is, the PA vessel is arteriogenesis or angiogenesis. For arteriogenesis, is induced after stenosis occlusive of a major artery. The initial trigger is fluid shear strength caused by altered blood flow through pre-existing collateral. For angiogenesis, usually the initial trigger is hypoxia, the growth of capillary from pre-existing vessels. In MMD patients, we can see 3 grades of collateral circulation. The grade 1 via circle of Willis, grade 2 via leptomeningeal collateral, and the grade 3 is arteriogenesis. So for PA score, for PA vessel, it's not only arteriogenesis, also including angiogenesis. This in normal human, the blood flow for medullary arteries from outside to inside. In MMD patients, the blood flow from medullary artery was changed from inside to outside. They will come from the blood from lenticular street or thalamic artery or choroidal artery. So how to evaluate the periventricular anastomosis? For the study from Japanese James trial, the most popular way to evaluate is the DSA results. Usually, if there were no dilation or no extension of these arteries, it will be considered as grade 0. When the dilation or extension was observed, however, below the level of pericallosal artery or below the level of lateral ventricle, it was considered as grade 1. For grade 2, the extension of periventricular anastomosis is dilation or extension beyond the level of the pericallosal artery or dilation beyond the level of lateral ventricle. In our center, we also evaluate these vessels, use DSA and classified the anastomosis as LSA, TTA, TPA, anterior choroidal artery and posterior choroidal artery. Besides DSA, there was some paper reported MR way to, for example, the high resolution MRI to quantitatively to evaluate LSA, THA, and CHA. They will summarize the total length of these vessels. So now we will talk something about the clinical significance of the periventricular anastomosis. It was related to the clinical manifestation. It's related to hemorrhage presentation, and also related to the prognosis and the pathogenesis of Moyamoya disease. So for clinical significance of periventricular anastomosis, this article is the first article to focus on this area. Professor Morika first reported the dilation and the extension of the anterior choroidal artery to predict the hemorrhage in adult Moyamoya patients. Is it normal? Is there something wrong in the internet?
It is not a full screen, Prof.
Sorry, because the lens has something wrong. I'll repair it for. Oh, it's okay. Sorry. So we will see the results from GEM trial, and also in Tiantan Hospital, we conduct some cohort to focus on the results of collateral vessels, the PA vessel in Moyamoya disease. In GEM trial, the hemorrhage was classified as anterior hemorrhage and posterior hemorrhage. The results support that a higher risk of hemorrhage in patients with periventricular anastomosis. The PA score was the sum of the grade of the three groups of periventricular anastomosis. The risk of hemorrhage increased with higher PA score. Moreover, PA score and the spatial distribution of recurrent hemorrhage. From these results, we can see for posterior hemorrhage, it was highly related to the choroidal artery dilation. So in our team, we conduct a retrospective study. We include 335 hemorrhagic MMD patients, including pediatric patients. This is the hemorrhagic pattern of our patients. The classification was similar to the standard of GEM study. This is the typical imaging for anterior hemorrhage and posterior hemorrhage. Our results is also the choroidal artery is the risk factor for posterior hemorrhage. Moreover, for patients without dilation of choroidal artery, hypertension increase the risk factor for anterior hemorrhage. This another study reported the posterior choroidal artery anastomosis. It was classified medial and lateral posterior choroidal artery. So in their results, the lateral posterior choroidal artery was associated with recurrent hemorrhage. this team further divided the potential anastomosis size of LSA, THA, and choroidal artery into medial medullary artery anastomosis and lateral medullary artery anastomosis, and the area with no medullary artery anastomosis. The results support that medial medullary artery anastomosis is associated with ipsilateral recurrent hemorrhage. So for the study, use DSA as the evaluation method. There were some limitations because we cannot quantitatively to evaluate the PA vessel, the PA anastomosis. So in this paper, they use high resolution MRI, and their way they calculate the total length of LSA, and the results is the total length of LSA is associated with anterior hemorrhage. It's an interesting results. Moreover, this study reported the enhancement sign of periventricular anastomosis from HR-MRI imaging. For the enhancement sign is associated hemorrhage. This result is similar to the results from aneurysm. So this team reported the 3D MRI results to establish the spatial distribution pattern of periventricular anastomosis in brain cortex. In this study, the lenticular striate anastomosis is supplied to anterior and medial cortex. The choroidal artery is supplied posterior cortex. Another important question is for asymptomatic Moyamoya disease patients. Is asymptomatic patients really asymptomatic? So this article compared the results from a GEM study and the cohort from a MO study. The results is very interesting. The choroidal anastomosis was similar between patients from hemorrhagic cohort and patients from asymptomatic cohort. It means maybe some patients from asymptomatic cohorts in future will develop a hemorrhage. So we need a long-term follow-up to confirm the results. Another important thing is the surgical treatment strategy for MMD patients. Usually we can use indirect bypass, direct bypass, or combined bypass surgery. Professor Xu is very famous for surgical treatment of Moyamoya disease. So from the results of a GEM study, patients with posterior hemorrhage will benefit from the direct revascular revision, and the endpoint is a recurrent hemorrhage. For pediatric hemorrhagic MMD patients, because pediatric hemorrhage in MMD is very rare, and this group, Professor Duan, report a large cohort. They use EDAS to treat pediatric hemorrhagic MMD patients. For the long-term follow-up, they observed the regression of anterior choroidal artery. So for pediatric hemorrhagic MMD patients, indirect bypass maybe also can help to prevent hemorrhage in future. This is a study to compare direct revascularization and for surgical hemisphere and the patients non-surgical hemisphere group. The PLBA score was lower after surgical treatment. We can see all anastomosis, periventricular anastomosis, including LSA, ophthalmic anastomosis, and the choroidal artery was decreased. So this picture shows the left side, the PA vessel. After surgery, the PA vessel regressed. For the non-surgical hemisphere, the PA vessel still here. So from this report, we know that the PA vessel can help us to predict hemorrhage and recurrent hemorrhage. Moreover, when we treat the hemorrhagic Moyamoya patients, except for the ischemic area, we need to the brain area, we need to provide more blood supply. We also need to consider how to decrease the dilation the periventricular anastomosis. Maybe these results will help us to evaluate the prognosis for hemorrhagic MMD patients and asymptomatic MMD patients. So last, I'll talk something about the research progression of periventricular anastomosis. This paper reported LSA will decrease with age, and the posterior communicating artery and the posterior carotid artery, the dilation will increase with age. The PA vessel transfer from anterior and to posterior with age was observed in this study. This study is very interesting. It compared the patients from Japan and the Caucasian, and also some Moyamoya disease patients from Caucasian. The authors reported the inter-ethnic difference of PA vessel on prevalence of hemorrhagic in MMD. In Japanese MMD patients, the anterior choroidal artery and the posterior choroidal artery, the dilation is significantly higher than that in Caucasian patients. Moreover, in Japanese patients, they observed significant dilated LSA in pediatric patients than adult MMD patients. And also the significant dilated posterior choroidal artery in adult patients, in pediatric patients. But this difference was not observed in Caucasian patients. So we all know that Moyamoya disease was more popular in East Asia, and also the genetic background of patients of Moyamoya disease is different from Caucasian and East Asia. RF213 was more reported and higher prevalent in East Asia. So we conduct a study to explore the association of RF213 variants and the periventricular anastomosis based on the MMD cohort. In this study, we include 260 patients, and sequencing of RF213 was performed, including ESA modular, including hinge-back, ring shell, RZ finger, core, and CTD region. This region was not included in our study. And then we compared the angiographic results and some clinical results. So this is the patients we included from 435 patients. We choose 260 patients involved in this study. In group 1, patients without RF213 rare and novel variants was classified into group 1. In group 2, the patient has 4A10 variant. In group 3, 23 patients was involved. They carried rare or novel variants besides 4A10 variant. We compared the periventricular anastomosis, the LSA, TTA, TPA, anterior choroidal artery and posterior choroidal artery, and the PA score. In our results, we found that the PA score was associated with age, with the number of platelet related to RF213 variant, and the Suzuki stage. It's hard to get MMD patients tissue sample for periventricular anastomosis. Is nearly we cannot get the sample, so we investigate Allen Brain Atlas and EQTL Atlas to see the expression for normal human brain, and for the Allen Brain Atlas, the expression of RF213 in normal human brain. After analysis, we found this gene was high expressed in basal ganglia, thalamus, and midbrain. In the picture, we can see in the red dot area. Moreover, we analyze the results from Brain Atlas. The expression of RF213 in normal human brain was similar to the Allen Atlas. The expression of this gene in white matter was significantly higher than in occipital, front, and temporal cortex. Increased expression of this gene in the periventricular regions was also observed. So from the clinical results and the genetical results and the expression analysis, our results is the trend of periventricular anastomosis was associated with RF213 variants. Patients with RF213 variant will have a higher periventricular score. The degree of PA was correlated with RF213 variant, age, platelet count, Suzuki stage, and PCA involvement. Higher expression in periventricular region and lower expression in brain cortex of RF213 was identified. So we speculate that this gene involves in the progress or arteriogenesis and angiogenesis in MMD patients. So this is that's all.
Thank you, Professor Zhang Qian, and it's a very informative presentation. And actually, in the Moyamoya disease, I think the dilation of the peripheral small vessels, including the ASA and the PA and this kind of small dilated vessel is also very important to carry the blood volume to the distal part of the cortex. And so the hypoxia also plays a very important role in the angiogenesis, just as you mentioned, in the distal cortex, because we can see the vessel density in the cortex is increased a lot, and definitely the angiogenesis was also play a very important role. Thank you. And I think, just as you mentioned, you mentioned a lot of very important find that the vessel is just like the aneurysm wall. Actually, in my opinion, the Moyamoya vessels network is just like a bunch of aneurysms, because it's a very thin vessel wall, tolerate the very high blood pressure in the inner cavity. So it should be like the aneurysm. And I think it's very important sometimes it's very important to do the enhanced MRI to predict the dangerous of the rupture. What's your opinion?
Thank you, Professor Xu. For Moyamoya patients, the periventricular anastomosis, sometimes the hemorrhage was related to some macroaneurysm, sometimes maybe from the direct rupture of the PA vessel. From the high resolution MRI imaging, some enhancement was observed for the ruptured periventricular anastomosis. So it's a very important direction, and we may use some maybe 70 Tesla MR to study this question, to solve this problem for our clinical treatment of Moyamoya disease. We should consider not only whether the patient is suffer from ischemic, but also the entire network of the patients. Thank you.
Yes, I think this is maybe we can use this enhanced vessel wall as dangerous factors for the hemorrhage. Maybe it means some emergency treat indication. Thank you.
Thank you,
Thank you.
Professor.
Professor Ali, you want to ask?
Yes, if I could, wonderful lecture. Thank you again. If I could just ask a backup question. Now that all of this wonderful research and insights, how do you approach an asymptomatic patient with advanced Moyamoya? How do you think of it? What is your imaging workup? Are there different subtypes that you would operate on? Take me through your process of how you do this.
Maybe in future we need more workshop or teamwork to collect the blood sample or some tissue sample and the clinical database or imaging database together and to conduct some cohort together in maybe in US, in Japan, and also I see a paper from Italy. There were a lot of neurosurgeon work together. It will help to finally find the real reason for this disease. We need for the rare disease, we need more cases. Thank you.
Ali, you mentioned the asymptomatic Moyamoya disease. Actually, in our treatment, in our clinic, most of the patients are asymptomatic because I believe that there's much more real asymptomatic patient wouldn't come for find the treatment to come to us, because most of them always have some TIA or IND or some stroke happened or some hemorrhage happened, then they will find the treatment.
Understood. Here we have, people are very image happy. You see a patient, imaging is done. So we see a number of patients that are asymptomatic, and then do you work up with vasomotor reactivity tests, SPECT tests to see if there's perfusion issues. But I think this information and looking at subtleties, maybe there's a stratification of which of these patients are going to become symptomatic and preventive sort of work. Thank you so much.
Okay, thank you.
I have one question, Professor Zhang. Thank you for interesting finding looking at the risk of hemorrhage between anterior and posterior circulation based on the type of periventricular anastomosis. May I ask, is there any pattern regarding the bleeding on the left and right based on your study, Prof? Left and right side. Is there any significant findings to predict whether left cerebral hemisphere or right cerebral hemisphere we have hemorrhage in the future?
In our study, our results were similar to the results from JAM study. The choroidal anastomosis is a predictor for posterior hemorrhage. We do not find any signs for to predict anterior hemorrhage. I think a study from Xuanwu Hospital, they use MRI to quantitatively to evaluate the periventricular anastomosis. They get the results. The LSA is related to anterior hemorrhage. But I'm not sure the results can be repeated or not in a big population. For example, in pediatric patients, we usually can observe a lot of Moyamoya vessel, not only LSA, but also thalamic anastomosis and choroidal anastomosis. So the pediatric patients maybe have some difference from between adult hemorrhagic patients, I think maybe.
Thank you, Professor Ben. You can ask.
Yes, evening, Professor Xu, and also Professor Zhang from Beijing. So thank you for your very insightful research. So my question is about, I saw you collecting the data about the pattern of the periventricular anastomosis. So may I ask, how does this pattern or this classification carry the clinical significance? So would that affect patient presentation or the pattern of the ischemic pictures, or would you consider to treat? Because, for example, you mentioned the choroidal type has a higher bleeding risk. So would you treat those asymptomatic choroidal types because of this? So yes, another question is about just now, Professor Xu mentioned about those histological pattern of the vessels. It's like it's aneurysm more like. So may I ask, do you have any experience in getting the histology or the histological differences between those microaneurysm associated with Moyamoya and those vessels from the ventricular vascular anastomosis? So thank you so much.
Thank you. So for the pattern of periventricular anastomosis, some was from the normal human brain. The blood flow is a very interesting article published 2 years ago from brain, and also some article reported the patients from MMD patients, the periventricular anastomosis pattern. This article, in each study, the number of the patients is relatively not so large. So when we compare these results, we need to pay much attention. For treatment, in my experience, I have do some hemorrhage, cerebral hemorrhage surgery, and also some Moyamoya bypass surgery. For the brain cerebral hemorrhage surgery, sometimes we treated 2 patients. They suffered from the rupture of MMD hemorrhage, and the vessel in the basal ganglia, the amount of vessel in basal ganglia, the periventricular anastomosis was not easy to calculate. This is my experience.
How about the histology? Do you notice any, or do you have any differences in the histology of those microaneurysm of Moyamoya and ventricular vascular anastomosis? Is there any experience in your side? Just for curiosity.
We do not have the histology samples.
Thank you so much.
Thank you, Dr. Ben. I don't see any other question in the chat box. So it's a great session for today. And may us now hear the concluding remark from Professor Zubin regarding the second lecture, Professor.
Okay, thank you, every speakers and host. And today we have more than 550 audience in WeChat channel, and they all enjoy your presentation very much. Thank you.
Thank you very much, Professor Zubin. So it's a time at the ending of today, 2 excellent presentation. So for the closing part, I would like to inform that on behalf of the Education Committee of the ACNS and the President, Professor Kato, I would like to thank both speakers of today, Professor Takahiro Ota and Professor Zhang Chiang, and as well as our chair, Professor Muhammad Aziz Sultan, and also Professor Zubin for the time and support for the ACNS webinar. I also would like to express my sincere gratitude to Professor Zubin again for broadcasting this webinar on WeChat channel. As what Professor mentioned, we have about 550 people join us live. And also special thanks to Ben for joining us today. So until we meet again online on 8th of April, it is bye-bye from all of us. Thank you for joining. Thank you, Professor.